If you were to take every single blood vessel in the human body and just lay them all out end to end, they would actually wrap around the Earth roughly 2.5 times.
Which is, I mean, just a staggering anatomical reality when you really think about
Right.
it.
But the truly wild part is that the vast majority of that 60,000-mile network isn't made up of the, massive arteries or major veins we typically picture.
No, not at all. It is almost entirely microscopic.
Yeah, we are talking about capillary beds so incredibly narrow that red blood cells literally have to fold themselves in half just to squeeze through in single file.
And because that microvascular network is so vast and so intimately connected to the function of every single cell in your body, when something goes wrong with it, the entire systemic infrastructure just crashes.
Yeah, the localized tissue destruction can be breathtakingly fast. So, welcome to today's deep dive. For you listening, our mission for this session is to explore a pretty towering stack of medical literature and specialized clinical guidelines.
Right, surrounding a highly complex group of diseases known collectively as vasculitis.
Exactly. And specifically, we were focusing deeply on the profound chain reaction that occurs when systemic vasculitis restricts microvascular blood flow to the body's tissues. We're going to trace the mechanics of how these microscopic vessels get choked off and the widespread downstream devastation that follows.
And the sources we're synthesizing today, they provide a remarkably comprehensive view of this pathology. I mean, we're pulling from the latest Vasculitis UK patient guidelines, a deeply detailed consensus statement from the British Menopause Society.
Which is fascinating, by the way.
Oh, absolutely. Plus some heavy textbook overviews on pathophysiology and several highly niche medical case reports. And together, they really illustrate a pathology that demands we look at the body as a single, fully integrated ecosystem.
Right. And because these medical texts are, let's be honest, incredibly dense, our goal is to cut straight to the core mechanics. We want to reveal exactly why these tiny blood vessels dictate your overall health, your tissue integrity, and even your fertility.
Yeah. To really grasp the bizarre systemic presentations of vasculitis, we first have to understand the mechanical reality of what is actually happening inside the lumen of those vessels.
Okay, let's unpack this. Because to organize the vast spectrum of these diseases, the rheumatology community uses what's called the Chapel Hill Consensus Framework.
Right, which classifies vasculitis based on the dominant caliber or size of the vessel affected.
Yeah, so you have your large vessel vasculitis targeting structures like the aorta, then medium vessel diseases, and then the small vessel vasculitis, which target the arterioles, the capillaries, and the postcapillary venules.
And it is within that microvasculature where the pathogenesis becomes incredibly insidious. I mean, vasculitis is fundamentally an autoimmune misfire.
A rogue immune response, basically.
Exactly. Due to genetic predispositions or specific pathogenic triggers, the immune system inappropriately identifies the endothelial cells lining your own blood vessels as foreign, so it initiates this relentless inflammatory cascade directly into the vessel wall.
And when that vessel wall becomes inflamed, the structural geometry actually changes. The vessel doesn't simply, dilate or expand outward like you might think.
No, the intimal layer undergoes severe hyperplasia. Fibrinoid necrosis sets in.
Right, the vessel wall actually thickens and swells inward, which rapidly decreases the luminal diameter. It's like a traffic jam on a tiny residential street versus a closed major highway. When the tiny microvascular streets, your capillaries, get blocked by inflammation, the specific houses or tissues they feed are completely starved.
That is a perfect analogy. And what's fascinating here is that the primary danger of the disease isn't localized merely to the damage of the vessel wall itself.
Right, it's the aftermath.
Yeah, it's the devastating downstream ischemic cascade. The capillary beds are completely obliterated by the inflammatory infiltrate, leading to profound hypoxia or lack of oxygen in the specific tissues those vessels were supposed to perfuse.
And you see that direct mechanical failure, perfectly illustrated in IgA vasculitis, because the pathogenic IgA immune complexes have a specific tropism, like an affinity, for the microvasculature in the dermis, the gastrointestinal tract, and the synovial lining of the joints.
Which is why the clinical presentation is so distinct, especially in kids. You get this non-blanching purpura on the lower extremities.
Wait, explain the non-blanching part for a second.
Sure. So the immune complexes trigger complement activation, the neutrophils literally destroy the vessel wall, and erythrocytes, red blood cells, extravasate directly into the surrounding tissue. Because the blood is completely outside the destroyed microvasculature, pressing on the skin doesn't turn the rash white. It doesn't blanch.
Oh, wow, because the blood is already leaked out into the skin.
Exactly. And simultaneously, because those same IgA complexes are depositing in the mesenteric microvasculature, the patient experiences severe abdominal angina.
So tummy aches, essentially.
Right, but severe. The gut tissue is literally screaming for oxygen because its capillary supply has been choked off by the inflammation. The root pathogenic mechanism is identical to the rash, just playing out in different anatomical capillary
Which
beds.
is wild. And we see an even more aggressive version of this in the ANCA-associated vasculitis, right? Like granulomatosis with polyangiitis, uh, GPA, and microscopic polyangiitis.
Yeah, MPA. In these cases, the autoantibodies are directly activating neutrophils, causing them to degranulate and release reactive oxygen species directly onto the endothelium of the kidneys and the lungs.
And the pulmonary capillaries are just remarkably fragile to begin with.
Oh, incredibly. When that ANCA-mediated neutrophil attack destroys the alveolar capillary basement membrane, the structural integrity of the lung tissue collapses. The patient presents with a life-threatening diffuse alveolar hemorrhage.
Wow.
Yeah, the rapid failure of that microscopic pulmonary plumbing is absolutely catastrophic.
So we've established the underlying pathophysiology of how microvascular flow is restricted or entirely destroyed. But since every tissue relies on that 60,000-mile vascular network we talked about, this localized starvation doesn't just happen in the lungs or the kidneys.
No, not at all.
The sources highlight that systemic vasculitis can present in wildly unexpected, seemingly disconnected ways.
It really acts as the ultimate diagnostic masquerader. Just consider the secondary vasculitis we see in Sjogren's syndrome.
Right, which people mostly associate with dry eyes and dry mouth.
Exactly. The primary mechanism of Sjogren's is lymphocytic infiltration of the exocrine glands, but the literature shows a significant subset of patients develop a secondary small vessel vasculitis. This often manifests as severe peripheral polyneuropathy.
So severe nerve pain. Because the vasa nervorum, the tiny network of blood vessels that actually supplies nutrients to the peripheral nerves themselves, becomes inflamed and occluded.
Yes, the nerve fibers literally undergo Wallerian degeneration because they are actively suffocating from a lack of arterial perfusion.
And then consider relapsing polychondritis, where the autoimmune inflammation specifically targets the proteoglycans in cartilaginous structures.
Right. Patients can present with bilateral auricular chondritis, which basically leads to a floppy ear deformity, a saddle nose deformity, and critically laryngotracheal involvement, where the airway cartilage completely collapses.
And the sources also tie this to the recently discovered VHS syndrome, right? Driven by somatic mutations in the UBA1 gene, predominantly observed in older males presenting with these exact cartilaginous and vascular inflammatory phenotypes.
Spot on.
Okay, wait. Floppy ears, dry eyes, and a collapsed trachea. I have to push back here. If I'm looking at a clinical chart and one patient has a collapsed airway, another has severe nerve pain, and a third, like the case report we'll get to, presents with a rapidly ulcerating breast lesion, how on earth do we trace all of these wildly different presentations back to the exact same microvascular pathology?
I mean, it is the ultimate challenge in rheumatological diagnostics, but if you connect the dots through the pathophysiology, the vascular system is the foundational common denominator.
Because it's literally everywhere.
Exactly. If circulating immune complexes or autoantibodies have an affinity for specific endothelial receptors, or if they precipitate in certain temperature-dependent capillary beds, the macroscopic symptoms will simply reflect the localized tissue ischemia. That breast lump you mentioned perfectly illustrates this tropism.
Yeah, the sources detail a highly specific case report of a 23-year-old Italian woman presenting with a painful, rapidly ulcerating mass in her right breast. And clinically, a necrotic breast lesion in a patient that young immediately triggers an aggressive oncological workup. They assume it's cancer.
Naturally. But her systemic history was the key. She had a documented history of recurrent oral aphthous ulcers and genital lesions, which led to a diagnosis of Behçet's disease.
Which is a unique variable vessel vasculitis, right? Characterized by intense neutrophilic vascular inflammation, and it's highly prevalent along the historic Silk Road populations.
Exactly. And instead of targeting the uvea of the eye or the large arteries as it normally might, the vasculitic inflammation targeted the microvasculature supplying her breast tissue, triggering autoimmune mastitis.
Wow. So the capillary occlusion caused localized tissue necrosis, resulting in the ulcerating lesion.
Yes. The case notes she was treated surgically, though the authors strongly caution that because Bisset's is heavily relapsing remitting, conservative immunomodulatory treatment is vastly preferred to avoid severe aesthetic damage from recurrent excisions.
It's just wild. The moment you recognize that localized tissue necrosis is really the endpoint of microvascular occlusion, these totally disparate symptoms suddenly align into a single, cohesive mechanical failure.
They really do.
Okay, here's where it gets really interesting. We're going to pivot to an anatomical region heavily detailed in the consensus statements but routinely marginalized in broader medical discourse, the pelvic microvasculature.
The historical blind spot regarding pelvic perfusion is profound. I mean, if you review the literature on pelvic hemodynamics, the overwhelming majority focuses on the mechanics of penile erection.
Right, erectile dysfunction.
Yeah. But the sources we are analyzing today demonstrate unequivocally that restricted microvascular flow fundamentally alters women's pelvic tissue integrity, structural elasticity, and overall autonomic function.
We see this explicitly in ischemic pelvic disease. When systemic vasculitis, or even advanced atherosclerotic disease, severely occludes the iliac or pudendal microvasculature, the pelvic floor undergoes chronic hypoxia.
Right. And the patients experience claudication-like symptoms in the pelvic region. So severe cramping, paresthesia or numbness in the perineum, and profound female sexual dysfunction stemming from a sheer inability to achieve clitoral and vaginal engorgement.
And the progression is tragically apparent in patients with systemic sclerosis, isn't it?
Yes. While the disease is phenotypically characterized by severe cutaneous and visceral fibrosis, that thickening of the skin, the primary initiating event is actually a profound obliterative vasculopathy.
So the blood vessels get choked off first.
Exactly. The endothelial injury happens long before the fibrosis. And in women, the severe restriction of pelvic and ovarian microvascular flow doesn't just cause mechanical sexual dysfunction. The chronic ischemic damage to the ovaries can actually precipitate premature ovarian insufficiency.
Early menopause, basically. And to drive home just how critical continuous microvascular perfusion is to pelvic tissue integrity, the British Menopause Society consensus draws a brilliant mechanical parallel to genitourinary syndrome of menopause, or GSM.
The pathophysiology maps perfectly onto the vasculitic model. GSM describes the systemic breakdown of the urogenital tract following the cessation of ovarian estrogen production.
Because estrogen is a highly potent vasodilator, right?
Right. It actively upregulates endothelial nitric oxide synthase, keeping the pelvic microvasculature robust and widely patent. It keeps the vessels open.
So when you remove estrogen from the system, you completely lose that nitric oxide-mediated vasodilation. The microvascular flow to the vaginal and vulvar tissue just plummets.
And the mechanical result is nearly identical to the ischemic starvation caused by vasculitis. Without adequate perfusion, the vaginal mucosa undergoes severe atrophy. It thins out, loses elasticity, and crucially, the epithelial cells stop producing intracellular glycogen,
Which triggers a cascading microbiological failure. Because glycogen is the primary food source for the endogenous lactobacilli species that maintain the vaginal microbiome.
Exactly. When the lactobacilli are starved of glycogen, they stop producing lactic acid. So the ambient vaginal pH spikes well above 5.0.
Which completely dismantles the local antimicrobial defense barrier, inviting opportunistic pathogens, causing painful intercourse, and driving recurrent lower urinary tract symptoms.
This raises an important question. I mean, how many patients are currently navigating the healthcare system, suffering from severe pelvic floor dysfunction, recurrent urgency, or vulvovaginal atrophy, and are simply told it is a standard consequence of quote-unquote aging?
Right, like it's just normal.
Exactly. When in reality, they are experiencing a highly definable, often reversible mechanical issue of restricted tissue perfusion.
And we also have to factor in iatrogenic microvascular damage here, meaning damage caused by medical treatment. The sources dedicate significant analysis to patients who have undergone pelvic radiotherapy for cervical or endometrial cancers.
Yeah, ionizing radiation causes double-strand DNA breaks directly in the endothelial cells lining the pelvic microvessels. These cells enter a senescent state, halting nitric oxide production and aggressively upregulating profibrotic cytokines like TGF-beta.
Which induces a condition known as endarteritis obliterans. The radiation triggers microthrombosis and intense perivascular fibrosis.
Right. The microvessels become rigid, heavily adherent, and their lumens slowly obliterate over the years following treatment.
So if a gynecologic oncologist has to re-enter that pelvis a decade later, the microvascular architecture is essentially encased in concrete, drastically elevating the risk of catastrophic hemorrhagic complications.
So we've established the absolute necessity of maintaining open, functional microvasculature. Whether the occlusion is driven by immune complexes, fibrotic remodeling, or radiation-induced endarteritis, the downstream tissue starvation is catastrophic.
Right, which dictates the therapeutic imperative. We have to halt the inflammatory cascade and restore perfusion.
But transitioning into our final segment on clinical management, the sources outline a pretty brutal pharmacological reality.
They do. The interventions required to arrest severe systemic vasculitis carry toxicities that can be just as devastating as the underlying pathology itself.
It is the central therapeutic dilemma in rheumatology. To prevent irreversible organ failure, you have to rapidly and aggressively suppress the rogue immune system. And historically, this has required massive doses of glucocorticoids combined with broad-spectrum cytotoxic agents.
Yeah, let's look at the mechanics of cyclophosphamide, which features heavily in the treatment guidelines. It is an alkylating agent. It works by cross-linking DNA, preventing cell division, which rapidly wipes out the aggressive lymphocytes driving the vasculitis. But because it doesn't distinguish between a pathogenic B cell and any other rapidly dividing cell in the body, the collateral damage is massive.
Particularly to the ovarian reserve. Cyclophosphamide is highly gonadotoxic. It aggressively induces apoptosis, or cell death, in the granulosa cells of the ovarian follicles. And the sources provide very specific data points on this threshold.
Yeah, they state a cumulative exposure of 14 to 20 grams of cyclophosphamide triggers primary ovarian failure in over 50% of female patients over the age of 32.
You are effectively curing the pulmonary hemorrhage or the glomerulonephritis, but you are chemically inducing permanent menopause and absolute infertility in the process.
It sounds like we're using a sledgehammer to fix the plumbing. Like you might stop the leak, but you risk breaking the entire sink, especially regarding a patient's fertility.
That's entirely accurate. Because of this, the guidelines mandate aggressive mitigation strategies. Rheumatologists pivot to shorter intravenous pulse regimens rather than continuous oral dosing to minimize the cumulative area under the curve exposure.
They also utilize GnRH agonists, right, like Zoladex during the infusion periods. The physiological goal is to completely suppress the hypothalamic pituitary ovarian axis, essentially putting the ovaries into a temporary quiescent state so the rapidly dividing follicular cells aren't actively targeted by the alkylating agent.
Exactly. Or, whenever clinically feasible, they transition to biologic agents like rituximab, which specifically targets the CD20 antigen on B cells, sparing the ovarian tissue entirely.
Right.
But the most exciting data in the sources revolves around the deployment of highly targeted molecular therapies.
Yeah, avacopan is a phenomenal example of this shift. It is a recently FDA-approved, orally administered C5a receptor antagonist used specifically for ANCA-associated vasculitis.
Rather than dropping a pharmacological bomb on the entire immune system, avacopan functions like a precision strike. In ANCA vasculitis, the complement cascade acts as a massive amplifier. The C5a protein is a potent chemodetractant that aggressively summons and activates neutrophils, directing them to destroy the vascular endothelium.
So avacopan specifically blocks that C5a receptor on the neutrophil. It cuts the communication line. The neutrophils never get the signal to attack the blood vessel, but the rest of the adaptive immune system remains largely intact.
Yes, and crucially, the clinical trials show this allows patients to drastically reduce or completely eliminate their reliance on highly toxic, long-term glucocorticoid regimens.
Which is huge. And we see equally fascinating mechanical ingenuity in how we are actively reversing microvascular occlusion in systemic sclerosis. We discussed the obliterative vasculopathy that chokes off perfusion to the acral limbs, driving severe Raynaud's phenomenon and triggering excruciating necrotic digital ulcers.
Right. The microvasculature in those digits is locked in a state of extreme vasospasm. And to force those vessels back open, rheumatologists are heavily utilizing PDE5 inhibitors.
Yeah.
Drugs like sildenafil and tadalafil.
Wait, really? Like the erectile dysfunction drugs?
Exactly, which most of the public immediately associates with male ED.
But physiologically, the mechanism is completely universal, right? The PDE5 enzyme is responsible for degrading cyclic GMP. And cyclic GMP is the exact intracellular messenger that signals the smooth muscle in the arterial wall to relax.
You've got it. By inhibiting PDE5, sildenafil prevents the degradation of cyclic GMP. The intracellular levels remain elevated, forcing continuous, robust vasodilation.
It doesn't matter if that smooth muscle is in the corpora cavernosa of the pelvis or the digital arteries of the index finger. The biochemical pathway is identical.
Completely identical. And the clinical data shows that utilizing low, continuous doses of sildenafil successfully overrides the vasospasm, dramatically increases capillary blood flow velocity, and provides enough oxygenated perfusion to actually heal those severe digital ulcers.
That is just incredible.
If we connect this to the bigger picture, rheumatological medicine is transitioning away from the era of blunt force immunosuppression. The collateral damage of broad cytotoxicity is simply too high. Understanding the exact molecular pathogenesis, whether it is blocking neutrophil chemoattractants with avacopan or forcing targeted vasodilation with sildenafil, represents the absolute pinnacle of modern disease modification.
We're learning to repair the plumbing without destroying the foundation.
Exactly.
So synthesizing this deep dive, it becomes incredibly clear that systemic vasculitis is the ultimate master of disguise. By mechanically restricting microvascular perfusion, it has the power to trigger a non-blanching dermatological rash, induce severe localized neuropathy, precipitate a necrotic breast mass, and catastrophically shut down pelvic autonomic function.
And for you, listening and processing this intricate web of pathology, it serves as a profound reminder of your own physiological infrastructure. We're conditioned to prioritize the macrostructures, right? Our heart, our brain, our musculoskeletal system.
Right, the big stuff.
Yeah, but understanding how intimately those organs depend on the continuous, unobstructed flow through microscopic capillary beds gives you a brilliant perspective on the fragility and the resilience of your systemic health.
It really forces you to view your own internal mechanics through an entirely new lens, and it leaves you with something deeply fascinating to mull over. Think about it. If our vast microvascular network is this acutely sensitive to transient inflammatory spikes, circulating immune complexes, and subtle hormonal fluctuations, how many everyday transient aches, sudden drops in stamina, or localized bouts of nerve sensitivity are actually just minor temporary microvascular occlusions?
That is a phenomenal concept to consider.
Right. How often are we casually writing off a tiny, localized ischemic event as simply having a bad day?
The next time you experience an unexplained fleeting ache, you might just be feeling the mechanical reality of a microscopic vascular compromise.
It really makes you think. Well, until next time, keep analyzing the hidden biological systems that dictate exactly how you function.